today's class is a very important and interesting topic that we are going to have a details look after, that is seizure and epilepsy.
So let's study seizure and epilepsy in a details way. Okay. So when I say seizure or the epilepsy, sometimes the students they may confused with that both are same. And some of them also having a partial knowledge about the seizure and the epilepsy. Usually हम लोग क्या सोचते हैं कि सीजर क्या है, एक एबनॉर्मल ब्रेन का डिस्चार्ज है और द न्यूरल डिस्चार्ज है, जहां पे पेशेंट्स का मोटर एक्टिविटी के साथ साथ उसका जो अवेयरनेस है, जो कॉन्शियस जो स्टेट है, उस पर ऑल्टरनेशंस आता है. लेकिन a seizure, what is the called a seizure? A classical definition of the seizure is it is a abnormal discharge of the brain or abnormal electrical activity of the central nervous system resulting in abnormal motor experience, abnormal sensory experience and abnormal psychomotor experience. See, we know that our brain is not only functioning motor, right? Our brain have a multiple functions, right? Every single to single activity, example, every single to single sense, emotions, feelings, along with some psychomotor movement, okay, some spatial senses like taste, touch, then smell, everything, single to single activity is controlling by our brain. So anything, neural changes which will be leading to the impulse or the electrical activity changes in the brain, the patients may have a seizure. And the seizure can occur at any conditions. If the patient is having any pathological condition, it may cause the seizure, but it is not epilepsy. Why? Example I'm giving. A person with hyperglycemia, he came to the hospital and there to control the glucose level, a nurse has administered insulin injection. So when the patient has received the insulin injection heavy dose, there is a suddenly fall of the glucose level. It means the patient has a hypoglycemic condition, and in a hypoglycemia what will happen? There will be a severe falling of blood sugar level, which will change the electrical activity of the brain, right? Here what happened, the person may experience the seizure, but we can't call it as epilepsy, because to treat that hypoglycemic condition, what we are providing a dextrose, either D10 or D25%, right, based upon the blood sugar level, because suddenly blood sugar has come down. So of course I have to maintain the blood sugar level. So what I will administer the dextrose solutions. When I will administer the dextrose solutions, the patient's blood glucose level again it will come to the normal, and that time the patients will be normal. So the patients may have experienced the seizure, but here we are not administering any kind of anti-epileptic drug. Okay, any anti-epileptic drug we are not providing. So we can call it as a seizure, but we can't call it as epilepsy. Then when we will call it as a epilepsy? Epilepsy is what? Is a repetitions of the seizure. So recurrent spontaneous tendency of the seizure. Okay, recurrent spontaneous tendency of the seizure, which clinically manifest is known as epilepsy. Okay, so we have learned in the seizure, the person can experience abnormal motor movement, abnormal sensory experience, abnormal psychomotor movement or experience. So epilepsy is what? Is the repetitions of the seizure. So in epilepsy, what will happen? The person may experience with either these three together, or sometimes any one of the experience, any one, okay, mark my word, any one of the spatial senses or motor movement or psychomotor experience abnormally the patients may experience. So we call as a epilepsy when these three either all together or either any one of them will be repetitive in nature, we can call it as a epilepsy. When a patients come to the hospital with some seizure condition, you have to diagnose first two things. That is, first, whether it is a true seizure or whether it is a pseudo or false seizure. And the second thing that you should not miss, that is, seizure and the epilepsy, we should not do the underdiagnose and we should not do the overdiagnose. Because if we are doing the underdiagnose, because हम लोग का एक स्टिग्मा, सोशल स्टिग्मा काम करते हैं, राइट, कि हम ये सोचते हैं कि जब सीजर एंड एपिलेप्सी है ये कोई डेमोनिक एक्टिविटीज है ना, हम उसको क्या करते हैं, सिर्फ और सिर्फ हम लोग का जो पढ़ाई का जो एक्सपीरियंस है वो सिर्फ और सिर्फ हम लोगों ने पढ़ा, देयर विल बी सम मोटर डिस्टर्बेंस अलोंग विद सम लॉस ऑफ कॉन्शियसनेस. बट हम लोग क्या कर देते हैं, ये जो दोनों पॉइंट है ना, सेंसोरी एक्सपीरियंस एंड साइकोमोटर एक्सपीरियंस को हम लोग अवॉइड कर देते हैं. हम सोचते हैं कि नहीं, इफ द पेशेंट इज हैविंग सम एबनॉर्मली सेंसरी एक्सपीरियंस और एबनॉर्मली साइकोमोटर एक्सपीरियंस, this can't be a seizure, this is something different disease condition. But it is also included in seizure because brain is not only controlling the psychomotor functions, it is also controlling the sensory functions, motor functions and all the functions, right? So when a seizure patients will come to the hospital, these two things you have to remember. Either you have to diagnose, not either, you have to diagnose the whether it is a true seizure or false seizure and whether it is a which kind of the patient is getting experience, either sensory experience, psychomotor experience or motor experience. Any one of the patients may have an abnormal experience. Okay. So therefore every seizure is not epilepsy. Okay. Before only I said a patient may have a seizure due to any pathological condition. Example, meningitis. Here I have given. You see, a meningitis patients can experience a seizure due to infection process of the brain. So with antibiotic treatments and with some other supportive treatments, we can reduce the infections and the patient seizure will be completely relief. But we don't need any kind of anti-epileptic drug to treat the conditions of the meningitis until the seizure is repeatedly occurring, and repeated occurring of the seizure we call it as a epilepsy. So until there is a epilepsy, we don't need to provide any kind of drug or the medicines. Clear? So that is the seizure and the epilepsy concept. Is the first concept. First, I will discuss about the seizure in a very detailed way, and then I'll be discussing the epilepsy. Okay. So we know that seizure is consist of three abnormal experience. The first one is motor, second one is sensory, third one is psychomotor experiences. So in that, the first point, that is abnormal motor experiences. Okay. So we know that if anything abnormal seen as electrical activity, that is affecting our somatomotor cortex of the brain. Okay, that is affecting our somatomotor cortex of the brain. Example, this part. Okay, look at this picture. This part is getting affected. What is happening? It is changing the neurotransmitter or the neurochemicals active neurochemicals alternations. Along with it is also changing the agonist and antagonist muscle activity, and that is resulting in motor functional loss. Okay, we know that. Example, you are lifting some object, heavy lifting you are doing. So what you are doing, you are flexing your hand. So when you are flexing your hand, what you is doing, your bicep is getting shorter, right? Look at this picture very carefully. Now imagine this is a normal patient. This is not a normal patient. Just imagine a normal patient, when they're lifting the weight, their bicep muscle, what is doing? It is getting squeezed, right? So what is another opposite, like tricep muscle is doing here? Tricep muscle is getting broadened, right? And when the patient is releasing the pressures, is relieving the weight, what is happening? The bicep muscle, it will come to the normal, and the tricep muscle is getting shorter. So they are working alternatively. But when the patient's somatomotor cortex region will be affected. Here it will cause the agonist and antagonist muscle. Agonist and antagonist muscle will be not functioning abnormally. Okay, sometimes they may work simultaneously or togetherly. Sometimes they may work alternatively but abnormally. They will not function normally. So when they will function abnormally, if the agonist and antagonist muscle, they contract together, what will happen? There will be a very stiffening of the body. The whole body will become stiffness, and that is known as tonic seizure. Am I clear now? The agonist and the antagonist muscle, they will contract together because of the somatomotor cortex of the brain has some problem, and that is changing the neuro impulse or the neural electrical activity, that resulting in the together contractions of the agonist and the antagonist muscle will resulting in severe stiffness of the body. That is known as tonic seizure. Okay, very understand. Now clonic seizure. Here what is happening? The agonist and the antagonist. Agonist is helping for the contractions, where the antagonist is helping for the broaden or the relaxations. So this muscle, they are working alternatively and abnormally. They should work, of course, alternatively, but there should be some, something should be there in a simultaneously. The rhythm should be there, but here they are working is a irrhythmic way. They are working abnormally. So what is happening here? The patient experiencing some jerking movement. You have seen, hopefully you have seen any patients, they have the fits and suddenly when they fall down, they have a very much jerking movement. They are shaking their body, right? They are not doing it by themselves. It is the somatomotor cortex problem where the agonist and the antagonist muscle is alternatively abnormally working. This both word you should mark, okay? Abnormally and alternatively they are working, where it is resulting in jerking movement. So that is known as clonic seizure. Okay, that's called clonic seizure. Now come to the tonic clonic seizure, which is also known as grand mal seizure. Okay, first the name itself is indicating there is a tonic seizure followed by the clonic seizure. Here I mentioned one video. Okay, this video will help you to understand. First you see the video, then I'll explain what is happening over here. Okay, here's a patient, right? There is a first stiffening of the muscle, tonic phase. Okay, after some time the patient is having jerking movement. From tonic it is converting to clonic phase. See, repeated muscle contraction and relaxations, what I said. Okay, intervals are getting longer, and followed by the patient is having no seizure, but the patient is also having lack of consciousness. See, clear with the video? See, so here first happened, what is happening here? The patient is having tonic phase, then after few seconds the patient is having clonic phase. It means the first the patient is getting stiffening, and then the patient is getting jerking movement, and after some time the patient is having no seizure, but the patient conscious levels has completely changed. There is a no conscious or lack of conscious is there. Okay, and that is called as tonic clonic seizure, or which is also known as grand mal seizure. Why this is happening? Because here the agonist and the antagonist muscle, sometimes they are working simultaneously or togetherly, and sometimes they are working alternatively, but both are working in abnormally. So when both thing is occurring, of course there will be a first tonic phase, then when they will work alternatively, it is leading to the from tonic to clonic. And when there is a no electrical disturbance in the brain, there is no seizure, and that period where there is no seizure, that is known as post-ictal period. What is known as post-ictal period? And this type of seizure, it can last up to 2 minutes. And also mark one thing, this type of seizure is very, very dangerous, okay, because it can repeatedly occur and the patients will not have any kind of consciousness. The patients, if it is taking longer than more than 5 minutes, the patients may die also sometimes, okay. Very, very severe changes will be there in the brain neurons activity, okay. That is called tonic clonic seizure or grand mal seizure. First there will be a tonic phase, from tonic to jerking movement, from jerking movement to then this phase, okay, where there is no seizure. Next come to the atonic seizure. Now what is atonic seizure? Atonic means A for absence, where there is a suddenly falling of CNS activity. The patients will have a sudden loss of consciousness or lack of awareness. That is known as atonic seizure. You may have seen some patient, they have suddenly fall down, or when they are doing some work while they are sitting, suddenly they have become senseless, okay. That indicating there is a suddenly falling off or fallen off electrical impulse of the brain, which is resulting in absence of the consciousness and the absence of the muscle activity, and that is known as atonic seizure. It is very simple, okay. Now the another one is myoclonic seizure, okay. What is myoclonic seizure? Let's have a video look. He's a patient, right? Is having the food. All of a sudden there is a jerking movement, but there is no changes in the awareness. Let's have a one more time look. Patient is having the food. Suddenly uncontrolled movement of the hand has occurred, right? Any one particular muscle or any part of the muscle which is uncontrolled jerking movement has occurred, but there is no changes in the awareness, okay. That is why it is known as myoclonic seizure. So now you have a doubt, sir, there was a jerking movement in myoclonic seizure and also there is a jerking movement is in clonic seizure. Then what is the difference? In myoclonic seizure there is no changes in the awareness, where in clonic seizure there is a changes in the awareness or the consciousness. That is the difference. In clonic seizure there will be a lack of awareness, and in the myoclonic seizure there will be a no changes of the awareness, but sudden and quick uncontrollable muscle movement will be there. That is why we call it as a myoclonic. Clear? And then another type is that is absence of seizure, or which is known as petit mal. This is very common in the children, okay. Why this is happening? This is same somatomotor cortex problem, where a few abnormal activity you may have seen. The patient may have a blinking of eyes frequently. They'll be doing the lip smacking, or they're walking, suddenly they have stopped, okay, or they're suddenly all of a few time they're staring into a particular point or particular any object for a few seconds, okay, and suddenly their involuntary hand movement, only the involuntary hand movement will be there, not only the complete hand like myoclonic, okay. Suddenly only the palm especially, their movement will be there. If such kind of activity you have observed in the patient, which is usually lasting 20 or 30 seconds, or sometimes it may less than 20 seconds also, it is indicating that the patient is having absence of seizure. Now don't think absence of seizure means there is no seizure. No, it is a not completely seizure, but it is a type of seizure which is affecting such kind of motion changes, Okay, like blinking of eyes, lip smacking, sudden motor stop, staring into one particular space for a few seconds, on involuntary hand movement, especially the palm movement will be there. Okay, the palm movement. Clear? So these are we have discussed about the abnormal motor experience. So let's revise one. Tonic seizure, stiffness, clonic seizure, jerking. Tonic clonic seizure, first stiffening, then jerking, and then unconscious. Myoclonic will be suddenly muscle movement will be disturbance without changes in the awareness, and absence of seizure will be some few of the abnormal activities will be present. So these many types of motor abnormal experience the patient may get in the seizure. Now come to the second, that is abnormal sensory experience. We know that a person can experience the sensory normally. There is a three types of sensory experience, that is somatic experience, some spatial sensory experiences, and visceral sensory experiences. Somatic, which is usually by the tactile stimulations or by the touch. So what happen? Any seizure that is occurring in the parietal lobe of the brain, especially the parietal part of the brain is getting affected, which is controlling our somatic experience, the touch experience. Here what happened? The patient may experience some unusual, unrecognizable tactile sensation, because we know, if anything, skin is the largest sensory organ, right? Skin. So what happens if anyone touches you, or any animal that you are familiar, example snake that has touched to your feet, you can easily understand that it is a snake. Your brain will process the informations and you can recognize that it is a snake, even though if you can't see the snake also. But what happen if parietal lobe neurons is getting damage or anything happen to the neural activity changes, the patients will have a unrecognizable, unusual tactile sensation. Sometimes the patients will feel that there is someone who is touching the patients. Sometimes the patients will feel that their hands is getting on fire, so that burning sensation they will have. We may find out, no, everything is fine, the patient is lying, but the patient is not lying. He is actually having that sensations. So don't ignore. That is why I previously only I said that we are ignoring this part, that's abnormal sensory experience part, we are completely ignoring in the cases of seizure. Okay, so somatic experience abnormally, if it is occurring, that can also a causes of seizure. Or other else, if any special part of the brain, example visual cortex, right, occipital lobe, if anything temporal lobe, if it any part which is our controlling spatial senses. What are the spatial senses we have? That is vision, taste, hearing and smell. The touch is as a general sense, but the main four spatial sense, that is vision, taste, hearing and smell. So if anything changes with the temporal lobe or occipital lobe or frontal lobe, right, that can lead to a abnormal, spatial senses changes. It means the patient can experience some sweetness in the mouth. The patient will complain to you that I am having some sweet sensation in my mouth. I can smell something which is not there. I can smell something bad. I can smell something breeze or the good smell which is not there. Where you cannot find there is no scent or no bad smell, but the patient may experience, because that particular part, that particular brain cortex part which is controlling the spatial senses, their neurons is getting discharged. So that is the reason the patient is having abnormal spatial experiences. It means the spatial sensory experiences. So don't ignore when the patient is saying that they're having some smell, some hearing problem, some taste or some abnormal vision. Don't think that it is related to some psychotic or some other conditions. It can also causes of a seizure. Next, come to the visual experience. What is the meaning of visual sensory experience? Example, person is aware about her own pain. Example, abdominal cramp. Right, abdominal cramp, what is happening? The patient is having repetitive abdominal muscle stiffening. So you may find out that the patient is physiologically completely normal. Then why they are complaining about the abdominal pain? You think that the patient is mad, but they are not mad, because there is a part of our brain which is known as insula, which is the pain pathway. If that is controlling, or that insula cortex is getting damaged, if anything electrical impulse changes in the insula part of the brain, the patients will feel a abdominal cramp repeatedly. So that is also a seizure. But you can't find out throughout the pain scale measurement. You will be finding there is no abdominal changes or no infections, nothing. Everything is normal. Then why they are complaining that they are having pain in the abdomen? Okay, there you have to think that can be a causes of the seizure of the insula part of the brain, and that is leading to the frequent abdominal pain of the patient. Okay, so there are 3 sensory experiences: somatic experiences, spatial senses, and visual experiences. So the persons can experiences, it means the abnormal experiences can occur either through the somatic experiences, through touch, either through the spatial abnormal experiences like abnormal vision, abnormal taste, abnormal hearing sound, and abnormal smell. And also the patient can complain about there is something pain on the abdomen, pain on the leg, on the hand, or any part inside, like visceral pain. The patients can complain. So don't think that if such kind of thing is occurring, the patient is mad or they are suffering from some psychiatric conditions. No, can be also causes of seizure of that particular spatial part of the cortex, which is leading to this many problems. Okay, that is why never ever underdiagnose the seizure and never ever overdiagnose the seizure. Both are harmful for the patients. Okay, so now let's come to the third one, that is abnormal psychomotor experience. Till now we have discussed about 2 things: motor experience and abnormal sensory experience. Now come to the abnormal psychomotor experience. See, we know that our brain is not only having a functions of motor or the sensory experiences. Our brain is also controlling our psychomotor movement. Example, emotions, memory, feelings, everything, right, which is associated with our some motor movement, some judgmental motor movement, also is controlling by our brain. So in that, especially which is helping, that is the temporal lobe. Okay, so temporal lobe is one of the part of our brain which is having a many functions. It is associated with your memory, associated with your emotions, sexual functions. Along with the temporal lobe is also associated with occipital lobe, and some of the junctions is there in parietal lobe, and also there is some part is associated with frontal lobe. So almost so many functions which is there in the temporal lobe is controlling. So if anything wrong with the temporal lobe, if it is radiating to the other junctions of the brain, that can lead to some specific problem, right? Example, the persons will have a memory disturbance. The person may experience some auditory hallucinations because temporal lobe is controlling the auditory functions. The patients may have some olfactory hallucinations, right? Also some abnormal sexual behavior the patient may do. Okay, so we may think that there are some other reason the patient is hypersexual or hyposexual activity is doing, or you may find out the patient is complaining about something bad smelling, or something they are pretending to be someone. Like example, they are thinking that they are made up of some wool ball or woolen ball, or they are feeling that they are made up of like a cotton ball. They can't perceive themselves who they are. So these all thinking, you are thinking that they may have some psychiatric conditions, so due to that they are doing some drama or they are doing something false, presentations. You may have recognized it, but it can be a seizure of the temporal lobe. And when the temporal cortex is getting seizure activity, the person may experience deja vu. Deja vu, right? Deja vu is a feeling of that something happened before and which is happening now. The same scenario the patients may have feel. The patients may have feel of jamais vu, just now I spoke. Then olfactory hallucinations, auditory hallucinations, and abnormal sexual functions also the patients may get. Okay, like premature puberty can occur if the temporal lobe is getting seizure. The small baby will have a sexual functions, hypersexual function. You may think that this is physically something changes is there, but there can be a causes of temporal cortex if the neuron is getting problem, which is producing the seizure activity, and that can lead to many problem in the psychomotor experience, abnormal psychomotor experience. Okay, so that is why never ever do the underdiagnosed seizure. We have to think broad way, okay, that there is a many functions of the brain which can get altered by the seizure activity, not only the motor activity. It can also associated with sensory perceptions. It can also associated with abnormal psychomotor experience the patients may have. Okay, so I'll finish it up with one revisions. What is we have studied about the seizure and epilepsy. Seizure is abnormal electrical activity resulting in abnormal motor experience, abnormal sensory experience, abnormal psychomotor experience. And every seizure is not epilepsy, because seizure can occur from any pathological conditions. We don't need to introduce or provide every time the anti-epileptic drug. We can treat it by the proper conditions also. And epilepsy we have studied, it is the repetitions of the three things: motor movements, sensory experiences, and abnormal psychomotor experiences. These three things, if it is repeatedly occur, we can call it as epilepsy. So in the motor experience, we have studied about the tonic seizure, clonic seizure, tonic-clonic seizure or grand mal seizure, atonic seizure, myoclonic seizure, and absence of seizure or petit mal seizure. In the abnormal sensory experiences, we have studied about the abnormal somatic experiences, abnormal spatial experiences, and abnormal visual experiences. And then we have discussed about the abnormal psychomotor experiences, where especially the temporal lobe, the limbic system, and the frontal cortex will be affecting. Okay, and due to that the persons will have some psychological issue along with motor movement disturbance. That is why we call it as a psychomotor experience. Okay, so these are the seizure types that we have studied. Okay, so next class I'll be continuing with the epilepsy and the rest of the part of the seizure.